Welcome back to Decode Healthcare with Harshal. I'm your lead instructor. Before we kick off, a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, so in part 138, we wrapped up advanced outpatient and ambulatory DRG integration, looking at things like APCs and inpatient-only procedure rules. Today, in part 139, we're doing a deep dive explainer to really trace the fascinating journey of an inpatient's chart. We're going to see exactly how the complex, messy reality of physical illness gets meticulously translated into a highly standardized financial product. It's this incredibly vital intersection of clinical care and revenue cycle management, and honestly, I'm so excited to walk you through it. Okay, let's take a quick look at our visual roadmap. We're going to systematically demystify all this by covering the DRG system, the foundations of ICD-10 coding, how we actually build an MS-DRG, the absolute power of clinical documentation integrity, and finally, compliance and metrics. But before we get into the weeds, we really need to nail down what a DRG actually is. A diagnosis-related group is exactly what it sounds like, right? It's a statistical way to group patients with similar clinical issues who are naturally going to need similar hospital resources. The big takeaway for you here is that under the inpatient prospective payment system, hospitals get paid a fixed amount based on this DRG grouping. They don't get paid a la carte for every single bandage, blood test, or hour of nursing care provided. Let's move into Section 1, the DRG system explained. This is literally the engine of reimbursement, so let's see how it operates in the real world. It really helps to think of a hospital's revenue cycle management as a highly specialized assembly line. It kicks off at patient admission, moves right into care delivery, where crucially everything has to be documented in the electronic health record, and then transitions over to the medical coders and DRG grouping software, before finally resulting in claims submission and payment. Now, if that documentation step fails, the entire assembly line essentially breaks down. To bake this final DRG product, our medical coders need a very specific recipe of ingredients. They absolutely need the principal diagnosis, the main reason the patient was admitted after study, but they also need all secondary diagnoses, the exact procedures performed, plus demographic data like age, gender, and the patient's discharge disposition. If you change even one ingredient in this recipe, you might end up with an entirely different DRG. Which brings us to Section 2, ICD-10 Coding Foundations. To feed our DRG recipe, we obviously need a highly standardized language. Notice the strict structural difference we have here between diagnosing an illness and coding the physical interventions. On the left side, we've got ICD-10-CM, which is used across all U.S. healthcare settings for diagnoses. These codes can be anywhere from 3 to 7 characters long. But over on the right, for inpatient procedures, we use ICD-10-PCS. And they are strictly 7 alphanumeric characters long, always, no more, no less. Let's actually deconstruct one of these PCS procedure codes character by character, because this is where the system gets really elegant. Every single alphanumeric value tells a vital part of the surgical story. Character 1 is the section, like medical and surgical. Character 2 is the body system. Character 3 is the root operation, so think excision versus resection. Then we move on to the specific body part, the approach, like whether it was open or percutaneous, the device used, and finally, a qualifier. You are literally building a custom code from scratch to perfectly describe a surgery. All right, Section 3, building the MS-DRG. Let's see what happens when we put those codes together and look at severity and multipliers. Now we feed those codes into the grouper engine, and this is where severity comes into play. The MS-DRG system generally groups conditions into 3 tiers, based entirely on secondary diagnoses. The presence of complications and comorbidities, which we call CCs, or major complications and comorbidities, MCCs, acts as a massive severity multiplier for the hospital's reimbursement. An MCC basically means the patient was incredibly sick, requiring way more nursing care and resources, which pushes their stay right up into that highest payment tier. It all comes down to this really simple math equation. The final hospital payment equals a geographically determined base rate multiplied by the DRG relative weight. Because an MCC pushes a patient into a higher tier, it directly increases that relative weight. Simply put, a higher relative weight means higher revenue for the facility, which is meant to cover the intense level of care they had to provide. Check out the stark financial contrast here between vague and precise documentation. Let's say a doctor broadly jots down shortness of breath and pneumonia for a diabetic patient. That might map to DRG 195, which is just a base payment. But if that chart is precisely documented to reflect the true clinical picture, meaning the patient actually had sepsis and their diabetes triggered diabetic ketoacidosis, which is an MCC, the DRG shifts completely to 871. The relative weight and therefore the payment literally more than doubles, all because the documentation finally matched the intense reality of the care provided.
Which leads us perfectly into Section 4, the power of clinical documentation integrity, or CDI.
This massive difference in payment highlights exactly why documentation just has to be flawless from the start. CDI specialists are essentially the vital bridge between clinical staff and the medical coders. They review records concurrently, meaning while the patient is still right there in the hospital. They intervene to prevent revenue loss by making sure the medical record truly, fully, and accurately reflects both the patient's severity of illness and their risk of mortality.
So what happens when chart notes are ambiguous or missing key adjectives? Well, CDI teams use formal queries. The quote here is a perfect example of a compliant query. Doctor, please clarify if the documented respiratory failure is acute, chronic, or both. Notice how it doesn't tell the doctor what to write? It's a non-leading query used to ethically optimize the DRG, ensuring the hospital gets fair credit for the complex care without risking a regulatory audit down the line.
Moving to our final section, Section 5, Compliance, Audits, and Metrics. Let's talk about how hospitals protect their revenue. Quality assurance is absolutely non-negotiable in this space. Hospitals use 3 distinct audit methodologies to spot systemic coding errors and stay strictly compliant with Medicare rules. Prospective audits catch errors before the bill even goes out the door. Concurrent audits happen real-time while the patient is in the bed, validating things like present on admission status. And retrospective audits look back at already paid claims to find trends and prevent future denials. A healthy revenue cycle is totally driven by data, making tracking these KPIs vital. The Case Mix Index, or CMI, is particularly fascinating. It's basically the average of all DRG weights assigned to a hospital's discharges. A high CMI proves that a hospital's coding accurately reflects the intense clinical complexity they're managing every day. If that CMI drops unexpectedly, that's a massive red flag that either documentation or coding is failing somewhere along the line. I'll leave you with this final thought to ponder. In this highly complex translation of healthcare data, from a hurried doctor's note to an ICD-10 code to an MS-DRG weight, precision is literally everything. Just one missing word, like failing to clarify acute versus chronic, could cost a hospital thousands of dollars on a single patient stay. Next time, in Part 140, we're going to explore mastering AI automated encoder algorithms and machine learning in DRG grouping, so you definitely won't want to miss that. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.